everyone, I am Anish. I am Mbbs student from Nepal Medical College, and in this video I'll be talking about rapidly progressive glomerulonephritis. So in this video I'll be talking about rapidly progressive glomerulonephritis. So that is R means rapid, P for progressing, G for glomerular, and for nephritis. And what does that means is that there will be rapid deterioration. There will be rapid deterioration of renal function. So there will be rapid compromise or deterioration of the renal function, and eventually that will result into renal failure in a period of couple of weeks to months, right? So how rapid is too rapid is that in a period less than 4 weeks is considered very rapid. So the all this process or all this phenomena should happen within a period of 4 weeks or within period of 4 weeks, and hence and within period of 4 weeks there will be rapid deterioration of renal function, and that condition is known as rapidly progressing glomerulonephritis, and it is a very important cause of acute renal failure. So it is a very important cause of acute renal failure, especially due to glomerular cause, right? And from the time of onset of clinical manifestation, so within a span of weeks to months, as I've said, within a span of weeks to months, especially less than 4 weeks, we can say that there will be rapid downhill course of this disease, and eventually that will manifest with renal failure. And what happens in renal failure is that it will manifest with symptoms of uremia and other features of uremia, other feature of renal failure like hyperkalemia. There can be acidosis, hyperuremia, increased ammonia toxicity. So that happens in case of RPGN. And RPGN, so RPGN can be due to various etiologies. So it is just a pattern of morphological change that happens in the glomerulus that can be seen in case of various etiological factors. And on the basis of various etiological factors and on the basis of immunofluorescence studies, we can classify RPGN into three categories like RPGN type 1, RPGN type 2, and RPGN type 3. So nevertheless, be it any etiology, the main hallmark feature in RPGN is that there will be rupture of the glomerular basement membrane. So notice the term I have said, rupture or damage, or there can be severe disruption of the glomerular basement membrane. So let us consider this is a glomerular basement membrane, and there will be severe disruption. So we can see at this point it has been broken down. So broken. Okay. So there is severe disruption of the glomerular basement membrane, and that will manifest with RPGN, which I'll be explaining right now. Right. So what happens in RPGN is that as I said, there will be severe disruption of the glomerular basement membrane. So there will be glomerular basement membrane breakdown or severe disruption, and that will result into leakage of large amount of plasma proteins. So larger plasma proteins will get leaked from that capillaries loop. Right. So let us see, this is a glomerular basement membrane, and that has been ruptured here. And because of this rupture, there will be leakage of a large amount of larger plasma protein and bigger part of plasma protein. And what are those proteins? They can be thrombin. So they can be thrombin. So, and also it can be fibrinogen. So fibrinogen. So usually in milder cases of glomerulonephritis, this larger amount of this large protein, so their size is very big, and they are not usually filtered from the glomerular in day-to-day scenarios, or even in case of pathologies within the glomerulus, which are not so severe. But when, as I have said, when there is severe disruption in the glomerular basement membrane, then there will be leakage of these proteins. So as I have said, there will be leakage of thrombin and fibrinogen, and this fibrinogen, by the help of thrombin, will be converted into fibrin. Okay, so this fibrinogen will be converted into fibrin, and this fibrin will be degraded into fibrin degraded products. So fibrin degraded products, and this fibrin, along with fibrin degraded products, it will be acting as a growth factor. So it will be acting as a growth factor, and this growth factor will lead to increased proliferation of the parietal epithelial cell, because it is acting as a growth factor. And because of this growth factor plus other cases of scenarios of inflammation, and it will result into proliferation of the parietal epithelial cell. Not just that, there will be proliferation of the neutrophil and infiltration of the neutrophil within the glomerulus, along with infiltration of other WBCs, and along with that there will be deposition of the fibrin. And these three components, that is parietal epithelial cell with infiltration of the neutrophil and the fibrin, it will contribute to formation of a crescent, and this will contribute to formation of crescent. And hence and crescent can be appreciated in the light microscopy of every etiology of RPGN, and hence this disease is also known as crescentic glomerulopathy. It is also known as crescentic glomerulopathy or crescentic glomerulonephritis. So how does it look in the light microscopy? So let us consider this is a light microscopy, and this is a crescentic glomerulopathy. So this is disease, and this is normal. So what happens, we can see in normal, there is, this is the parietal epithelial cell. So this is a parietal epithelial cell, and these are our capillary loops, and these capillary loops have a visceral epithelium on them, and the basement membrane as well. So this is normal. But what happens in a disease format is that, so these are parietal epithelial. So we can see here, this is parietal epithelial cell, and these are our glomerular capillaries. So we can see this. And what happens is that there will be increased proliferation of this parietal epithelial cell. Not just that, there will be increased infiltration of the neutrophil. So I'll be making neutrophil in this color. So increased infiltration of the neutrophil, and along with that, as I said, there will be filtration of the fibrin. So fibrin will also be filtrated, and these three components with together make up what I said is a crescent. So you can see this is a typical crescent that you can be appreciated in the light microscopy. So this is a crescent that can be appreciated in a light microscopy. So because of this crescent, as we can see here, the Bowman space, the space in the Bowman space has been compromised. And because of this compromised space, the filtration will not be so good. And that will result into decrease in the GFR. So decrease in the glomerular filtration rate, and eventual decrease in the filtration. And because of this decreased filtration, this will manifest with oliguria. So oliguria. And because of this oliguria, when there is a less amount of urine that is formed, lesser than 400 ml per day, then that condition is known as oliguria. And because of this oliguria, as most of the components are not being filtered from the blood, this will manifest with and this oliguria will manifest with nephritic syndrome. So it will manifest with nephritic syndrome, because as most of the things are not being filtered, the increased amount, there will be increased amount of blood, urea, nitrogen, and creatinine. And this increased amount of blood, urea, nitrogen, and creatinine in the blood will get started to deposit in various tissues, and that may result into uremia. So that will result into uremia. And because of the severe disruption, there will be leakage of the RBC through the disrupted glomerular basement membrane, and that will result into hematuria. So that will result into hematuria. Along with that, what we can see is we can see uremia, we can see hematuria. Not just that, we can also see that as there has been severe compromise in the GFR, there will be intrarenal ischemia. So the intrarenal ischemia will be developed, and because of this, there will be severe activation of renin, angiotensin, aldosterone system. And because of this activation of renin, angiotensin, aldosterone system, there will be severe and persistent hypertension. So severe and persistent hypertension will be seen. And because of this hypertension, what we see in the gross morphology of the kidney is that we'll be seeing petechial hemorrhagic spots on the surface of the kidney. So let us consider this a kidney, and we can see the cortical surface of the kidney has numerous blood vessels, and because of increased blood pressure, the blood vessel will undergo rupture, and hence we can see different hemorrhagic spot in the kidney, and this appearance of kidney is known as flea-bitten appearance. So flea-bitten appearance. So I have discussed about gross pathology on what do we expect on RPGN. So what I said is that on the light microscopy, you should see crescents. You should see crescent on the light microscopy. On electron microscopy, every single RPGN, whether it be type 1, type 2, or type 3, we should appreciate GBM rupture, so glomerular basement membrane rupture, and wrinkling of the glomerular basement membrane. So wrinkling of the glomerular basement membrane along with GBM rupture. And in the gross appearance, we should appreciate the flea-bitten appearance of kidney. So flea-bitten appearance of kidney should be appreciated, and these three features must be appreciated in all form of RPGN. And RPGN is called so because there is rapid deterioration of renal function, as we have already seen. How does that happen? And this will result into severe persistent hypertension along with the severe features of nephritic syndrome. And now we'll be discussing about the individual etiology on RPGN. So RPGN does not denote the specific disease or anything. It is just a morphological change that we appreciate in the glomerulus, and it can be due to several etiology. So it is a syndrome associated with several glomerular injury because of other glomerular diseases, and it is rapid and progressive loss of renal function, and death from the renal failure can occur within weeks to months. As I have already said that the deterioration will happen in less than 4 weeks. So deterioration will happen in less than 4 weeks, and this rapid deterioration is known as RPGN. So it is also known as crescent glomerulopathy, as I've already said why it is called so. So we can classify RPGN. So let me give an overall about the etiological factor and different types of RPGN. So RPGN can be broadly classified as type 1 RPGN. So type 1 RPGN, and let us make another row about type 2 RPGN. So type 2 RPGN, and let us make one more row about type 3 RPGN. So Type 3 RPGN. So type 1 RPGN is also known as anti-glomerular basement membrane anti. So let me correct myself. So type 1 RPGN, it is mostly due to formation of autoantibodies against the glomerular basement membrane. So type 1 RPGN is formed. It is mostly due to formation of autoantibodies against the glomerular basement membrane, and it can be due to idiopathic cause where we cannot identify a single cause to that disease, or it can be mostly due to Good-Pasteur syndrome. So regarding Good-Pasteur syndrome, I'll be discussing it in detail about the congenital nephritic diseases, which will be uploaded very soon in the channel. So in type 1 RPGN, it is mostly due to formation of autoantibodies against glomerular basement membrane. So this is a type of which this is a type 2 hypersensitivity reaction. So type 2 hypersensitivity reaction. So why it is called as type 2 hypersensitivity reaction? Because the antigen is present within the glomerular basement membrane and it is intrinsic. All right, but the antibody, they are formed by the body, and they are usually they are circulating in our body, and eventually that will be filtered and they will get deposited within this intrinsic antigen, which is present throughout the glomerular basement membrane, and hence this is known as type 2 antibody type 2 hypersensitivity reaction. Whereas type 2 RPGN, so let us discuss about type 2 RPGN. In type 2 RPGN, there will be production of immune complex. So whenever I say there will be production of immune complex, so it is sure said that it is a type 3 hypersensitivity reaction. So it is a type 3 hypersensitivity reaction. So it is a type 3 hypersensitivity reaction because we can see immune complexes in the blood, and most of the cases here are idiopathic. We do not know exact cause behind that, but usually, as I have said, that it is a immune complex mediated disease, so it should have an antigen, it should have an antibody. So antibody is produced by our body, whereas antigen should be can be foreign or can be endogenous as well. So what can be the antigen? So antigen can be produced due to infections, so it can be due to infectious etiologies, and it can be due to SLE as well. So it can be due to SLE, it can be due to hemolytic uremic syndrome, where there will be production of a toxin. It can be also due to thrombotic thrombocytopenic purpura, or it can also be due to IgA nephropathy, also known as Buerger disease. So even Buerger disease can result into a morphological change in the kidney, hence that by the name of type 2 RPGN. So we know different etiology of type 1 and type 2 RPGN. So let us discuss now about type 3 RPGN. So it is the matter of fact that type 3 RPGN is the most common rapidly progressive RPGN. So type 3 RPGN is the most common RPGN, and sadly there will be no immune complex, neither there will be antibody, and it is known as pauci-immune. So it is known as pauci-immune. It is called as pauci-immune because there will be no antigen and no antibody, and it is usually associated with vasculitic disorder. So vasculitic disorder, and those vasculitic disorder which is associated with ANCAs. So ANCA means anti-neutrophilic cytoplasmic antibodies. So ANCA can be C ANCA or it can be P ANCA. C means cytoplasmic and P means perinuclear. So cytoplasmic ANCAs can be seen in case of diseases like Wegener's granulomatosis, and P ANCAs can be seen in diseases like microscopic angiopathies. So in vasculitic disorder like Wegener's granulomatosis and microscopic angiopathy, we can appreciate in the late course of disease, it can result into RPGN, and that RPGN will be characteristic of type 3 RPGN. Right? So we have known about the different etiologies. So let us discuss it right now. Right? So type 1 RPGN, it is called, the cause is an autoantibody which is forming against the glomerular basement membrane. So anti-glomerular basement membrane antibody, and the one of the disease that is limited to it is Good-Pasteur syndrome. Right? So Good-Pasteur syndrome will attack the autoantibody, especially the non-collagenous domain in the glomerular basement membrane, that will be discussing in the nephritic congenital nephritic disease as well. So it will affect the basement membrane in case of lungs and in case of kidney. So in kidney it will result into RPGN, whereas in lung it will manifest with hemoptysis. So you must know that Good-Pasteur will affect lungs as well as kidney as well. So in case of type 2 RPGN, it is due to deposition of immune complex, hence it is a type 3 hypersensitive reaction. So it is a type 3 hypersensitive reaction, and it has several etiology, like it can be due to APGN, that is PSGN, as I have said in the last video of PSGN, it can result into RPGN type 2. It can be due to SLE as well. It can be due to Hinault online purpura. It can be due to IgA nephropathy or Buerger disease. It can be due to Buerger disease, and as I've already said, it can be due to HUS, hemolytic uremic syndrome, thrombotic thrombocytopenic purpura. It can be due to several other diseases like that, like this. Right? So, and the next one is type 3, and the type 3, as I've said, it is associated with vasculitic diseases, and the vasculitic disease which is usually associated with ANCAs, and it can be due to P ANCAs or it can be due to C ANCAs, and because of this, we cannot appreciate any antigen or antibody in this disease, hence it is known as pauci-immune. So it is known as pauci-immune. So we know the different types of different types of RPGN. We can classify it as type 1, type 2, and type 3. On the basis of etiology, I classified it, but we should know that we should know something more beyond that, right? So what we should be knowing about it is that in type 1 RPGN, we saw there was an auto antibody which was targeting our own intrinsic antigen. So the treatment of choice will be plasmapheresis in this condition. So plasmapheresis should be done, and while doing plasmapheresis, we will be removing this autoantibody from our blood, and hence we'll be treating type 1 RPGN. Whereas in case of type 2 RPGN, the treatment of the choice is treating the primary cause. So as we can see, it is due to several secondary causes like APGN, SLE. It can be due to HSP. It can be due to IgA nephropathy. So the treatment of choice is that we should treat the primary cause in case of type 2 RPGN, right? And in case of type 3 RPGN, we should treat the underlying vasculitic disease. So underlying vasculitic disease should be treated, right? So regardless of the different etiologies, as I've already discussed, the morphological changes that we'll be seeing in case of RPGN, that will be in the light microscopy and in the gross feature, that will be very similar in all cases, right? We should be able to differentiate it in terms of immunofluorescence study and in terms of electron microscopy, and that's it. And I'll be discussing it in a moment, right? So let's discuss about the morphology of RPGN. And in the RPGN, as I've said, the kidney will be enlarged, and there will be production of there will be petechial hemorrhage on the cortical surface of kidney, and hence the appearance of kidney is known as flea-bitten appearance. So flea-bitten appearance of the kidney is seen, as I've already said. You can see numerous petechial spots on the cortical surface of kidney, and that is due to severe hypertension. So that is due to severe hypertension is the cause of this, and it can be appreciated in all types of RPGN, whether it be type 1, type 2, and type 3. I've also discussed in detail about the crescents, and in crescent I said that it is formed by 3 important components, and one of the important component was parietal epithelial cells, and this parietal epithelial cell proliferation. Along with that, I have said inflammatory cells, and this inflammatory cell in the bound space can be monocyte, it can be neutrophil, it can be macrophage, it can be a lymphocyte, and as I have already said, it can be due to fibrin strands. And these 3 components will result into formation of crescent, and this crescent will look like this, as you can appreciate this. So you can see this is a crescent in a glomerulus, and hence this is also known as crescentic glomerulopathy. So we can also appreciate crescent in this diagram. So notice the fact that in type 1 or type 2, or whether it be type 3 glomerulopathy, you can, in all of this, you can appreciate this form of crescent, right? And this crescent is very pathognomic for crescentic glomerulopathy or RPGN. And also, I have already said the flea-bitten appearance on the cortical surface is also pathognomic for all the type of RPGN, and it should be seen in all the type of RPGN. And that is a hallmark, and that denotes that the renal function is being compromised so severely. Eh? And the morphology of RPGN, as we can see that now because of this crescent, the actual Bowman space has been compromised, and because of this, that will result into oliguria and subsequent feature of nephritic syndrome. And now we will be seeing the electron microscopic finding on RPGN, and what we will be seeing in RPGN, in every cases of RPGN, whether it be type 1, type 2, or type 3, we should appreciate the ruptures in the glomerular basement membrane. As I've already said, the ruptures of the glomerular basement membrane, along with wrinkling of the glomerular basement membrane, wrinkling and rupture of the glomerular basement membrane. And because of this rupture, there has been leakage of fibrin and thrombin, and this has led to entire pathogenesis of crescentic glomerulopathy. So so we must see that. So see this is our glomerular basement membrane, and we can appreciate the wrinkling of the glomerular basement membrane. See this. So we can see the wrinkling, and at this point there has been a rupture to the glomerular basement. There is no glomerular basement membrane. At this point also there is no glomerular basement membrane, and because of this, the substances will get filtered here, and the substance that will filter is fibrin, and also I have already discussed about thrombin will get filtered here, and eventually that will result into formation of crescent. That is very pathognomic for RPGN. Okay. So in this way, we have completed about the different types of RPGN, the different morphological findings in RPGN, and different etiologies in RPGN, and different treatment strategies in RPGN. But I have yet to complete RPGN because I have to tell about immunofluorescence studies in RPGN as well. And this is how you differentiate type 1 versus type 2 versus type 3 RPGN. And they are distinguished mainly on the basis of immunofluorescence study. So in type 1 RPGN, so as I've already said, type 1 RPGN is a type 2 hypersensitivity reaction, and there will be production of autoantibody, and this autoantibody will target the glomerular basement membrane. So let us consider this is a glomerular basement membrane, and the autoantibody will target this glomerular basement membrane, right? And because of this targeting, when we'll be using anti-human globulin, which is tagged with a fluorescent dye, so anti-human globulin tagged with a fluorescent dye, and whenever we'll be seeing it in immunofluorescence study, there will be diffuse pattern of immunofluorescence. So diffuse pattern of immunofluorescence will be seen here, right? So in type 1 immunofluorescence study, we will be seeing diffuse pattern of immunofluorescence, so it should be noted. And in type 2 immunofluorescence, so as I've already said, type 2 is mostly due to PSCN and SLE and other causes like that. So in type 2 RPGN, there is deposition of the immune complex, and the immune complex is deposited in, especially in the subepithelial area. So let me make this an endothelium. So this is our endothelium, this is our glomerular basement membrane, and this is our podocytes. So these are our podocytes, right? So whenever so there has been deposit of autoantibody, so antigen antibody in the subepithelial area. See, autoantigen antibody in the subepithelial area. And whenever I'll be using anti-human globulin, let us consider this an anti-human globulin, which is tagged with fluorescent dye, and it will give a granular pattern of immunofluorescence, and there will be granular pattern of immunofluorescence in type 2 RPGN. So it should be noted that in type 1 RPGN, we'll be seeing diffuse pattern of immunofluorescence, whereas in type 2, we'll be seeing granular pattern of immunofluorescence. I hope you understand by this schematic diagram why do we see granular and why do we see diffuse in type 1. Whereas in type 3 in type 3 RPGN, we do not see any immune complex, because I have said that it is due to it is also called as immune, because we do not see any immune complex. But what we demonstrate is we will demonstrate ANCAs. So ANCAs should be demonstrated via serological test, and this is how we differentiate different type of RPGN on the basis of their etiology, on the basis of their immunofluorescence staining patterns. And this is all about RPGN and its content. And we should be knowing that we should very severely and aggressively treat this disease, and the treatment measure has already been discussed in the beginning of the lecture videos I have already discussed here. So I thank you very much for your patient listening. So we'll be meeting each other while discussing IgA nephropathy or Border disease. So thank you very much.